I'm going to talk to you about DAPT in the era of NOACS. It's a little bit actually long kind of topic, so I might exceed the time limit. Just bear with me if you don't mind. So I have nothing to disclose here. So I thought I'll start off with a real-time case just to give you the flavor of what kind of patients you'll be dealing with. And then I'll introduce some essential data on DAPT and NOACS. And then we'll try to find out whatever available in terms of using both. And then we'll go back to the case, and then we sum up the findings and the conclusions. So Mr. WH is a 67-year-old male with an ER visits in May 2014 with worsening shortness of breath over 2 weeks' time. He has no chest pain, palpitations, or syncope. His presentations at that time was consistent with exacerbations of heart failure. His cardiac risk factors include hypertension, diabetes, and dyslipidemia. He's got an extensive past medical history. As you could see, he had a PCI done into the LAD in 2004. He's also had an AV block with pacemaker insertions in 2013. He's also known to have obstructive sleep apnea, CPAP. He had atrial fibrillation with ablation that was partially successful, but basically then it remets in 2008. He had also carotid endarterectomies and cancers of colon that was resected in 2009. So I don't think you have a complex patients that could hold all these findings, but this is realities. So medication, dabigatran, 110 milligram BID with metoprolol, 25 milligram POBID, Lipitors, amlodipines, and some other medications. So his heart failure symptoms was improved on IV Lasix. His echo showed functioning bioprosthetic aortic valve with mild gradient. His left ventricular function was normal apart from septal and apical akinesis. His angiogram at this time showed chronic total occlusions at the RCA, LAD de novo lesion at 90% we thought to be the culprit, and a circ lesion that is 50%. The patient underwent PCI to the culprit LAD on May 22, 2005, utilizing everolimus drug-eluting stents. So the questions now, what should we do with the antiplatelet treatment in the presence of oral anticoagulations? What are the choices that we have in hand? Aspirin, Plavix, warfarin, stop dabigatran, clopidogrel versus with warfarin, dabigatran with clopidogrel and aspirin. For how long, and what other considerations would you do for these patients? So dual antiplatelet treatment has been proven to be efficacious and essential in patients with acute coronary syndrome in several trials, as you could see. So the typical or the first anti-ADP medication that was introduced was actually the ticlopidine, but because of high complication rate due to TTP, it was basically fall out of favor. Then clopidogrel was basically the leaders in terms of the second antiplatelet that has been added to the aspirin. Several trials have shown actually its effect, including the CURE, CREDO, CAPRI, Charisma trials, and many others in patients with ACS and post-stenting to prevent thrombosis and major adverse cardiac event. What about the new DAPT that we have in hand? We have at least two of them that has been actually already proven by the FDA. We have prasugrel and ticagrelor. Now, prasugrel was studied in the Triton-TIMI 38. The primary result, as depicted, showed significant actually reductions in the composite endpoints of composite endpoint of cardiovascular death, MI, and stroke on the expense of increased TIMI major bleeding that was statistically significant. On the other hand, ticagrelor, which is a BID dose anti-ADP medications, was actually proven to be efficacious based on the BLEEDIG trial, which showed also decrease in the major adverse cardiac events without significant increase in bleeding. So how do these two new dual antiplatelet treatment differ from clopidogrel? So we know that we have the thienopyridine group, which is basically have the thienopyridine ring, and that basically the clopidogrel and the prasugrel. Ticagrelor is a non-thienopyridine anti-ADP or PTY12 receptor blocker, which has actually a functions or an action similar to the thienopyridine groups. Now, if you look at the prodrug, clopidogrel actually is a prodrug, but it requires actually at least 2 enzymatic reactions in the liver before it becomes an active medication. On the other hand, prasugrel will need only one step, so it's actually much faster than clopidogrel. The CYP2C19, which was actually a problem and sometimes in 2005, particularly in patients who are using the proton pump inhibitors, is not actually involved in the prasugrel metabolism. Drug-drug interactions is actually also less with prasugrel. It has been studied in STEMIs and non-STEMI patients. The problem with prasugrel, it's a very potent drug. It basically works very quickly, and it has very high risk of bleeding, probably double the risk of Plavix. And that's why we cannot use it in patients with history of TIA. We try to avoid it in obese patients and elderly patients above the age of 75. Ticagrelor, on the other hand, is a BID dose. Its structure is similar to adenosine, hence some of the patients might have complaint of bradycardia as well as bronchospasm, but it's a BID dose. It has lower risk of bleeding and probably much more utilized nowadays in some centers because it's also fast-acting medications that doesn't require the metabolic reactions that are required for Plavix. So if you look at the guidelines, basically DAPT is indicated in patients with acute coronary syndromes and post-stentings. We say between 6 and 12 months for drug-eluting stents, about 1 month for bare metal stents. However, the most recently published studies, which is the DAPT trials, published in New England Journal of Medicine in December 2014, show that extensive timing of the use of dual antiplatelet treatment might be also helpful. It reduces major adverse cardiac events, stent thrombosis, on the expense of increased risk of bleeding. So I'll shift gear now to the NOACS, or the new oral anticoagulants. So what's the novelties about these medications? Why did they call them novels? Actually, probably the most important things that they hinder them actually much more useful is that the fact that you do not need to monitor their anticoagulation's effect. Their efficacy is probably equal, particularly with rivaroxaban, or superiors with dabigatran and apixaban. Bleedings is equal with dabigatran, rivaroxaban, and lesser with apixaban, with lower intracranial hemorrhage in all of them. Stability is the dose versus the effect in all NOACS versus warfarin. Drug interactions is much lesser with the NOACS compared to the warfarin. It's much more tolerated with lesser GI bleeds. There is no need for monitoring, as I mentioned. The only downside is probably cost, because they are much more expensive than warfarin. So how do they act? So dabigatran actually is a modification of zelmigatran, which was introduced, I think, in 2003, 2005, but it fell out of favor because of high risk of liver toxicity. It basically works as a direct thrombin inhibitors. Now the newer one, including the rivaroxaban, apixaban, and andexaban, actually work as a direct factor Xa inhibitors. The metabolism actually varies and differs. So dabigatran is more of a renally excreted medications. Rivaroxaban and apixaban is basically liver excreted medications, and doxaban basically excreted from both. What were they indicated for? So far, they're indicated for 2 main indications: non-valvular AFib and VTE-PE, venous thromboembolic diseases. And you could see which one is FDA approved and which one isn't. So dabigatran, rivaroxaban, apixaban, and edoxaban. In non-valvular AFib, the seminal trials that was actually introduced are the RIE, the Rocket AFib, and the Aristotle, and it shows that they have equivalent efficacy to warfarin with lower risk of bleeding. They're also being approved for DVT and PEs in RECOVER-B, Einstein DVTs, Einstein PE, and Hockesel VTE. There are other NOACS in the pipe as well. They've basically been introduced but haven't been proven yet for specific indications. So what about follow-ups of these patients? All patients, they need to be assessed for compliance. They have to ask about thromboembolic phenomena, bleeding risk, other side effect, interactions with medications. And then you have to follow up with routine blood tests depending on their creatinine clearance, particularly if you're dealing with renally excreted medications. Bleeding and need for reversal. So far, I'll talk about the Antidotes that has been introduced recently, but so far the way we deal with bleedings in NOACS is actually just a supportive treatment. You might use the prothrombin complex concentrates and the activated factor 7, if you wish, in extreme, extreme bleedings or life-threatening bleeding. What about the antidotes? Recently introduced, there is a new antidote called the Antidotes, which is basically a recombinant glycoprotein that inhibits the serine at position 419, switch it to alanine, and basically deactivate the abiaxapan. I think there is a randomized control trial that is going on at this point in time with rivaroxapan as well as abiaxapan. Okay, what about NOACS and acute coronary syndrome? So there has been actually 3 trials that was basically introduced and it was actually studied. One of them is the UPRAISE-2 trial, which studied abiaxapan as an antiplatelet treatment in patients with acute coronary syndrome. These patients were randomized to abiaxapan plus the DOAL antiplatelet treatment versus placebo with DOAL antiplatelet treatments. And they were looking at the major adverse cardiac event and risk of bleedings. In this particular trial, which is a UPRAISE trial, there was no improvement in the major adverse cardiac event. However, there was increased risk of bleeding that was statistically significant. The second trial is what we call the ATLAS-2 trial, or the ATLAS-TIMI 51 trial, which studied actually rivaroxapans in patients with recent acute coronary syndrome. Patients were basically randomized to placebo versus 2.5 or 5 milligram of rivaroxapan over a mean period of 13 months in addition to the standard DOAL antiplatelet treatment. And this particular trial showed statistically significant improvement in major adverse cardiac event compared to placebo with lower risk of bleeding when you use the 2.5 dose. So remember, this trial, the ATLAS, was positive, the UPRAISE was negative. There was also the RUBY-1 trial, and the RUBY-1 trial actually was on the diraxapan. Unfortunately, this was underpowered, so it didn't reach statistical significance in terms of MACE, but there was definitely an increased risk of bleeding. So what did we learn from these 3 trials? So important observations in the UPRAISE-2, ATLAS, ACS, TIMI 46, and RUBY suggest that in patients with a recent acute coronary syndrome, very low dose of an oral anticoagulant, particularly speaking rivaroxapan, as I just showed you in the ATLAS trials, appear to be favorable. However, this did not actually change the guidelines so far because it's 1 out of 3 trials. So what about the guidelines? So there is no specific guidelines as far as the ACC-AHA, but the European Heart Rhythm Society will give you a general idea of how to do when you face a patient who's already on NOACS in terms of acute coronary event. What you have to do is to stop the NOAC at first, then you start your antiplatelet treatment that you're supposed to start. You favorably probably will start with the fastest P2Y12 like ticagrelor. And then basically you take the patient to the cath lab. Preferably you put bare metal stent if you think the patient has other additional risk factors that needed actually anticoagulation for. And these are the general guidelines that you could go and study or read from the European Heart Rhythm Societies. You could use heparin or at least 1 anticoagulants in the cath lab, preferably heparin or basically the bivalirudins for basically its short acting. Avoid glycoprotein to be inhibitors as mentioned in the guidelines. What about triple therapy? So what about DAPT in addition to NOACS as a triple therapy? So in this scenarios, I think what you have to do as an astute physician is to try to balance the stroke and ischemic event versus the bleeding risk. So we know that we have several risk factors that came about actually quite recently. Is ischemic risk scoring, stroke risk scoring, which is SHA-S2 or the SHA-VASC, depending on which one you think is more practical. For me, SHA-S2 is better from a practical standpoint of view, probably. Bleeding has bled, as already you know. So this is the SHA-S2 and the SHA-A2, DS2, VASC modifications that all of you are familiar with. And then the has bled with its component. And you know that the cutoff value of 3 could discriminate higher risk of bleeding versus lower risk of bleeding. So far, how could we make an incentive, how could we make a good decisions about these cases? And how could we tailor the treatment based on the patient's profile? I think it all boiled down to this diagram. So triple in the centers of the diagrams, the benefit is you're gonna reduce probably the ischemic event on the expense of bleeding. Dual, you're probably okay. I'm gonna show you a study that probably go with that, but you probably increase the risk of ischemic event. Single, no one probably would use, particularly if you have acute coronary syndrome in the presence of stent placement. So the pre-NOACS, one of the studies that actually gained lots of interest was the WAS trials. It was published or presented in the European Society of Cardiology, I believe in 2013, if I'm not mistaken, I think 2013. So it was exclusions of aspirin out of the triple therapy kind of protocol. Does it really change the major adverse cardiac events or the MACE? And in fact, it didn't. However, it lowers the risk of bleeding. So something to keep in mind, that you could drop one of the antiplatelets and keep anticoagulations if you want to use the triple treatments. So is that all? I think we still have lots of questions that haven't been answered yet. So what about the guideline? Just to show there's a little bit of variations in terms of the European. So I don't know how to use the pointers. I'm trying to use it, but okay, what about this? Okay. So if you look at the European Society of Cardiology versus the ACCP or American College of Chest Physician guidelines, there's a bit of variations in terms of the bare metal versus drug-eluting stents versus acute coronary syndromes. The bottom line is, if you want to use the triple treatments in the presence of bare metal stent, you could use aspirin Plavix for 1 month and just warfarin. If you want to go with a drug-eluting stent, you use aspirin and Plavix, minimum of 3 months if you're using the Olimus or sirolimus kind of biodegradable material versus the Taxils, you should go for 6 months. Plavix will go for a long time in addition to warfarin. Acute coronary syndrome, aspirin for 6 months, clopidogrel for 12 months, and warfarin. Don't ask me what's the evidence of these kind of things. I think the evidence is more depicted here. I'm totally biased, but this is basically based on the trial that I show you. So bare metal stent, you could go just with aspirin Plavix for 1 month, then 1 antiplatelet treatment in addition to anticoagulations with warfarin. Based on the WAS trials, you could use either aspirin Plavix plus warfarin long term. Based on the GRACE trial, you could use also either one of them with the coumarin. So other question. So what else could we do to prevent bleedings? What is there any preferred kind of stent that would use? I think bare metal stents was a drug-eluting stent. So if you were to choose between both in patients who would need triple, probably you would go with the bare metal stent. Shorter durations, as we mentioned to you. I haven't put it in a slide, but there has been a significant shift in terms of short-term versus long-term dual antiplatelet treatment with the third-generation drug-eluting stents. There is a big meta-analysis that was published in JACC in 2005, which showed similar outcome if you use short-term dual antiplatelet, i.e. 3 to 6 months versus 12 months, in addition to anticoagulations. So what about triple therapy? There is no studies as of yet with the NOACS. What is in the pipe? There is a Pioneer AFib PCI trials. And this is a trial, I think, that has been already launched. They start recruiting, and this is the design of the studies. So patient will be randomized to aspirin Plavix or aspirin and prasugrel versus rivaroxaban with high dose and low dose versus placebos, and they will basically they will follow for a period of 12 months to see what will be their outcome.
2 minutes.
So as we stand, NOACS and DAPT efficacy evidence is lacking. Bleeding risk is high. Definitions differ if you look at the AFib trial versus the ACS trial. Patient characteristics as well is different. Doses in ACS trial differ as I mentioned before. So back to Mr. WH, triple therapy prescribed and discharged. We stopped dabigatran because there was no evidence. We didn't know what to do with it. warfarin, Plavix, and aspirin until August 2014, which is about 3 months. Target INR at low level about 2 to 2.5. Add PPI for GI protection if you wish. Warfarin plus aspirin until May 2015, and then resume dabigatran 150 after the 1-year landmark if the patients prefer to go that way. So in summary, ideal combinations of antiplatelet therapies and anticoagulation does not exist in patients with atrial fibrillations and ACS as a triple therapy. Need to be individualized based on risk of oral anticoagulations. Risk stratification is helpful with the risk score that we have. Limit durations of triple oral anticoagulation to reduce risk of bleeding. Educate your patients that risk and benefit, provide GI protections, and may consider using bare metal stents versus drug-eluting stents. And I'll conclude here. Thank you.
Thank you.